Hey, I'm Jim Wiedrick. Every day I'm working to transform healthcare in Southeast BC. My big idea is to look for ways that we can improve the system. And my YouTube podcast and all of the efforts herein are designed to create one on one conversations, stimulate thought, pull the curtain back, show people how the system's actually working, and to ask the question, hey, what can we do better? What's working in the system? How can we actually leverage the issues that are going on so that everybody gets actually better healthcare? And we don't just talk about it, but move in good directions. Today, I am really grateful to be joined by a colleague from Kootenay Lake Hospital, Britt Murdoch. And Britt is a nurse I got to meet when she came into the role of patient care coordinator in our emergency department. She's subsequently moved on, and her official title now is Shift Supervisor. And I am happy to have you today, Britt. How are you doing?
Good, yeah, good. Thanks.
So, Britt, if you don't mind, just give us an opener and tell us a little bit about your journey. How did you end up in Nelson? What's led you to the place that you're at in terms of your work today?
Well, I went into nursing right out of high school. I graduated nursing school in 2007, and I got a job in Toronto in 2007 as a new grad in Emerge. And that was a 6-month preceptorship in Sunnybrook Hospital. It's a trauma center. Um, They get all the big traumas from the 401. And it was a really good experience. There were 6 of us that were hired. Um, we had a preceptor for 6 months, and we went to George Brown College for our emergency training program. And then I worked there for 6 months. And then my boyfriend, who's now my husband, we moved to Vancouver, and I got a job at VGH as a 21-year-old emerge nurse, very young, just experienced like in Toronto, so that was a big leap. And I worked there for 10 years, had 2 mat leaves, and then had 2 young kids living in Coquitlam, commuting to Vancouver, and my husband got a job offer out here at the pulp mill in Castlegar, and we moved to Nelson. And I got a casual position at Kootenay Lake Hospital in the Emerge there, and I just picked up whenever my kids had childcare. And fast forward a year and a half, and the patient care coordinator position in the Emerge there opened up, and I fought being in a leadership role for years and years in Emerge at VGH, and just felt like the right time for me to jump into a leadership role in an emergency setting, which is my love. And worked there for 2 years and got um, they started this shift coordinator position at KLH, which really spoke to me. The hours were really great, and the work-life balance seemed really good. It was team working. We work with there's 4 of us, so I like the idea of working with a team. And so that's where I am now. Really
Yeah, that's
happy.
cool. So you have
hmm
spanned the spectrum of nursing care from what I think Nelson can be properly considered as a primary care hospital, and then
hmm
you've worked the tertiary,
hmm
and some people would even call some of those services quaternary environments, and I want to explore that a little bit with you. I mean, I'm a guy who grew up in rural Alberta, and I had the opportunity in the 90s to live and work for one summer in Toronto. And my memory of the 401 that you referenced, the big highway that runs as a ribbon through there, was there was 12 lanes. And they were talking about core and collector. And I'm like, what? What? And so,
Yeah,
it's almost quaint if you've grown up in an urban metro center to think
totally.
like that. But here I am driving my 1986 Gold Dodge pickup, trying to get into the core and not knowing what's going on.
It's wild, man.
And so I'm gonna go and dive a little deeper with you on that. Like, what's the difference from your point of view working in a big center, BGH Sunnybrook,
You
or
have
working
everything.
in Nelson?
Yeah, at a big center, you have everything. You don't realize you have everything. You think you think you need more, but you have everything. You have the patients have everything they need. Absolutely everything. They have a trauma surgeon, they have an ortho, they have a neuro, they have a spine, they have burns, they have like you have everything. It's it's
And if you
incredible.
if you're sort of the average member of the public, how would they receive slash perceive that? And would it be would there be other sort of practical ways that that showed up? So, like, if I roll into the hospital, here I am at your hospital in Sunnybrook or VGH, or your hospital in Nelson. What's the difference? What's the practical difference? How does it? How does the patient live that?
The volume of people is different. Um, the volume of people that are trying to get in to get one of those services um, is greater, and um, the need is triaged. So you don't maybe you feel like you need to see a service that Vancouver would have, but possibly there's about 10 other people who are worse off than you, and those people will get the service before you. So you may feel like you are not going to be able to get the service that you know is right there, but you have to wait a little bit longer because the volume of people I think is just greater. And here we have some specialties you have to travel further, but you do have to wait for things here as well because there's so few. Like, for example, cardiac services at KGH. That's one cardiac service hospital for a massive region. So people are waiting longer to get into to this site, right? So I think it's the volume of people, and then here um, it's the services that they offer, but they're so few. Does that make sense? So it makes the volume more.
Well, I think so,
That
and I think one of the things that I heard you sort of hinting at was that the rate limiting step in our site is really transportation because we've got to get out to that center, Kelowna General
yeah,
Hospital, that is maybe
yes,
serving the 1 million people of interior health. And hey, it takes minimum 5 hours to get there, plus a lot of organizing. Whereas if you were sitting at Vancouver General Hospital, maybe there's other sicker people in front of you, but there's a whole, opportunity to float immediately up to the top of the triage list and have a face-to-face encounter with that specialist right away.
yeah. Or they come down and see you right away and say, "Oh no, you don't need to be admitted. Like, do this for follow up." Or like, there's other options. There's like outpatient things, and there's I don't know how many hospitals in the Lower Mainland have cardiac services, but I know it's not one. So I think that the fact that there's other ways to get what you need, whereas here you have to travel farther and there's less services available. Like, there's one cardiac service available in this region. That's just an example, but same with plastics, same with neurosurge, same with, spine, you have to go to Vancouver. So I think that would be the biggest difference is in the Lower Mainland. Uh, the services are there. It's just the general population is so much bigger. And here it's the population is large because there's only one service center. Does that
So I know
make
kind of
sense?
what it's like to operate as a physician in those environments, and I've had to learn to be, assertive on the phone. I've
Hmm.
had to learn to be comfortable taking that remote guidance and doing procedures based off of it or something like that. So what's it like to be on the nursing side of things? Like, what's your experience when you're working at a primary care hospital versus a tertiary care hospital? Do you have different satisfactions, different kind of shift to shift kind of moments or
I think
enlightenments?
I think it's humbling for sure to be here witnessing things that if you were at a different center, you would get them quicker. And sometimes speed is life, right? Like, we know that with brain, with anything that um, needs, you know, time is of the essence for certain things, trauma, cardiac, brain health, all those things. So I think that it's humbling to see people choosing to live here, like ourselves, because it's the quality of life you live. You know, when you're living this high quality life. You're not surrounded by crowds and crowds of people. You can be if you want to be, but you can also drive 10 minutes and you're alone in the forest, or you're down by the beach in the water, you know what I mean? Without crowds of people, places to park. You're not fighting for this wonderful land that we live on. You get to experience it without, you don't have to experience it with tons of people. So I think it's the quality of life that we get to live here. And I think a lot of people choose to live here. And when they get sick, they travel or go places that, you know, if you're sick and you need cardiac services or cancer care, you know that you're going to have to go. Or maybe you don't and you find it out and, you know, put your big boy pants on and get going because you don't really have a choice. I mean, you do, but one is, you know, you stay here and do nothing, and one is you move and you travel and you do stuff. So I think it's very humbling to see all the people that live here and um, you know, choose to live here. Most of
Yeah,
us.
I love the way you frame that because I have often said that I really want to live here. And I know
Yeah,
if I get one of two or three key conditions that I won't make it to a big hospital in time. But, well,
yeah.
if,
But you lived,
if
right?
that's what Providence has designed for me, then que sera, sera. Yeah.
Yeah,
So, what, as you sort of step back and you think about the state of nursing in our region, let's just stick to southeastern BC for the moment.
sure. Okay.
How would you describe we're doing from a nursing point of view? And I'll give you one thing that was in the news that I'd love to hear your comment on, and that is that in the last 3 to 6 months, you know, the BC government has now instilled some patient nurse ratio kind of
Hmm.
direction and whatnot. So I'd love to hear a comment on how you see that's working and just the state of nursing in general from you where you sit.
I would say that patient nurse ratio, I don't think it's come out just yet, but it's coming.
Language
And
was spoken.
I, yeah, and I think that will be helpful. And the reason I say it will be helpful is because I feel like nursing right now is stretched very thin. And I think that people are feeling that. And I think the hope with saying patient ratios increase, or like the ratios decreasing, um, is the support that the nurses will feel when caring for their patients. Because I think a lot of yeah, this is a very touchy subject. I think that they need support, and I think that power in numbers is one of the ways that they will get the support. I think nursing in this region, um, as well, is also a work-life balance. I think a lot of people who are nurses want to be nurses to help people, but also to live their life. They have really good schedules. You know, not a lot of people work full time. A lot of people have half time work, point 0.5, 0.75, point 0.8. You know, there's all these little points that don't equal full time, which I think is a big draw for nursing, because like we've just said, is that you live here, you want to live, you don't want to be working all the time, you want to work so that you can pay for your lifestyle. And the fact that people don't have to work full time to pay for their lifestyle here, I think is something that's really great. But when they are at work, I think they need to be supported.
Right? So people want to work to live. They don't want to live to work, and that's somewhat of a generational shift. Totally fair. And then I heard you emphasize that there does need to be movement in concepts like these patient to nurse ratios that have been proposed and discussed about, because basically during a shift, folks just feel overstretched. There's too much going on. Yeah.
Yeah.
Certainly I've seen some
They
night
need to
shifts
be
where,
supported.
too many people to look after, too many sick folks in our emerge, and not enough bodies to run around and do all the things that have to be done sometimes.
That's right. Yeah, that's right.
Do you think, acknowledging that not every person chooses to work a full-time equivalent, I get that easy enough. Do you think we have enough nurses? I know that there's kind of some natural cycles in terms of how long people
Yeah.
spend nursing in certain areas. Like not everyone who's an emerge nurse is 73 years old anymore.
No.
But do you think we have enough nurses overall?
I think currently, right now, there's enough nurses in KLH Hospital um, to fill the lines. I mean, there are a few vacant lines, but there are people who are going through like training and stuff. Um, and there's some new grads coming in. Do I think we have enough nurses to fill the new patient ratios? I don't know. I think that you always have to be hiring because you never know who you're going to lose. You always have to be thinking ahead. You always have to be thinking, you know, if we're going to get these patient ratios, we got to get some more staff. We have to hire some more staff. There aren't any agency nurses working there currently, and they're baseline staffed, if not baseline to workload staffed, which is really great for Kootenay Lake. But like you said, it is ebbs and flows. Like from my experience as an emerge nurse, there's just sometimes you're really staffed, and then there's these times where you're just really not staffed, and it's really hard to get staff in. And I think that should just, you can't be too hard on yourself. You just have to remember it's ebbs and flows. And when you're in the low, you just kind of, you know, try really hard to get more staff, try really hard to hire people, try to get agency nurses, whatever you have to do to support your staff that's there, I think is the biggest thing. Supporting the staff on the ground, I think is the best way to, boost morale and have people, want to come to work.
Yeah, I totally understand
Because
that.
they don't have to pick up. Like this is what I'm saying about this area is that they don't have to pick up. Some people don't need the money to have to go to work and deal with, low staff or whatever. So they don't have to go to work. So to make work enjoyable is to be supported, I think.
Right. If in the system we have to establish this like elasticity or resiliency, the ability to flex up
Resiliency.
and down, and yet the actual practitioners, I mean, my observation is that maybe it's a generalized statement, but there's kind of a little bit of care burnout, and possibly
Oh
the
yeah.
pandemic had something to do with that. And just providers are feeling like that provider or care fatigue somewhat.
Yeah.
Is that a fair comment that from where you sit?
Yeah, I think that's really fair. And I think a lot of it too, a big burnout piece also is mental health and the difficulty in getting care in this region for mental health, and long-term care placements, I would say, on the medical floor is causing a lot of burnout. You have to get matched, and I think and it's a process that is in place because you need to make sure people go to where they need to go. But I would say that, yeah, that's causing caregiver burnout. They just, what are we doing for these people? It kind of is kind of, it weighs on you, these people come for help, and it's like, well, if you can't get them into a certain facility to see someone who's the specialist there, what are we, we're just prolonging. It's just kind of hard sometimes, I think, for the nurses.
So a couple of comments that I've heard you mention that I'm going to follow up on in your answers. I mean, one was the acknowledgement that many of the patients on our medical floor, and the number goes up and down, I know, but are actually truly awaiting long-term care placement, might not need an acute care bed, except we have no long-term care beds that they could move into. Um, And then the other concept that I heard you talk about was agency nurses. So maybe we'll do it one at a time, but long-term care beds, is there any other way the system can help those folks other than just plain out and out having more facilities, more sort of auxiliary care options that are out there? Is there anything that you hear about in your discussions that comes up and you're like, well, if we only did that different or better, that would work?
No, I guess having more people be able to stay home longer with support that way would be the other option to placement. I think there's a lot of people who don't want to go to a long-term care place, but it's unsafe for them to go back home. Whether it be they don't have anyone to care for them, whether it be, there's no services there, whatever it may be. But I think that being able to stay home longer might be beneficial to people, but it has to be safe for them. We don't want to put people at risk. And some people choose to live at risk, which is, again, their decision. Um, yeah, I would say that would probably be the biggest thing. I know that in Vancouver, my friend's working on this thing. She's a manager of, it's called Hospital at Home.
Hospital at home.
Yeah,
Okay.
have you ever heard of it?
Nope. I'm
So
open
there,
to.
it's a pilot project that Vancouver Coastal Health launched. I don't know much about it, but it's Hospital at Home, it's called. And they have like staff and they go in and they give antibiotics and do stuff that you would do in the hospital, but they do it in their home.
Actually, I love it. I mean, that's exactly the kind of thing that I'm wanting to uncover with some of these conversations. So I could see how that would be easier, perhaps, to set up in an area with higher population density. Do you think that we would have enough in the town of Nelson? I mean, maybe if you lived outside of Nelson, that would be hard, but do you think we could do it in the town of
I
Nelson or
don't
similar
know
sized
much.
towns?
I don't think I know much enough about it and like what the resources are and who they need to, how they need to run it. But I know that they just started doing it last year. It, it's it, it's something that maybe eventually would trickle down. Like I'm sure it would have to start at a bigger center first to figure out, maybe something if Interior Health ever did pick it up, it would be something like in Kelowna first, and then they would figure out how to make it more rural.
These are
But
totally the kind of pilot projects that I wanna learn more about. So that's cool.
yeah, it is really cool. Really cool.
I'll shift gears just for a little bit because there's been a lot of conversation in the news and with like healthcare budgeting and whatnot around the phrase agency nurses. So these are what some people would know as travel nurses or folks who come in on a contract. They might not live in your area, but they come in on a fairly well compensated contract to help
Very
cover
well.
certain shifts that otherwise weren't going to get covered.
Yeah.
So, from your point of view as like a shift coordinator and someone who is a little bit in an oversight role, what's your take on where we've been with agency nurses, where the future's going to go with that, or what we should or shouldn't be doing around that topic?
I'm for agency nurses. If we cannot get staff to come to these remote locations and we just have to pay them a bit more to get them to come and they can experience, like there's a few agency nurses we've picked up.
Right? They
Like
came for a
they've
while and then they
come to
stayed for a good
Nelson,
long time.
yeah, and they have positions now. So, I mean, it's essentially like nurses shopping around for the place that they want to end up, honestly. And if we get our staffing beefed up and maybe they come with really high, like a few of them have come with like a lot of experience and high standards of care and, working with really sick people. And they have that comfort of being able to just jump into a situation. Um, yeah, I say if we're having trouble, covering shifts, I have no issue with bringing people in. Again, I don't deal with budgets though, so
Well, yeah,
that's probably the difference.
but like my the logic side of my brain says sometimes there have to be market incentives, and if XYZ is not being filled, but it would be if you paid more for XYZ, I don't know another way around it. I mean, you tell me how else we should solve this problem. Are we just going to conscript folks and make them do something against their desires or wills? That doesn't seem cool.
Mhm.
So, yeah.
No.
One of the things that I thought about when you were saying that agency nurses help bring knowledge from other centers, maybe they came from high impact centers or whatnot. It's kind of similar in medical education when we have the residents. The residents kind of help keep all the local staff physicians up to speed on what is being discussed at the higher
Hmm.
levels of academic teaching hospitals and things like that. And it keeps everything fresh. You don't get stuck in ruts. So I can see some benefits to just having that flow in and out of some folks from out of town. That makes sense to me.
Yeah, and there's some staff that work at Kootenay Lake that are agency nurses other places. So
Okay,
they
so you mean
go
like they have a
away.
position here, but then they spend
Yes.
some of their time going and
Yeah.
doing
Yeah.
stints?
And gaining experience. I think the biggest thing about a small rural hospital is when people stay here and only work in the small hospital. When they go out and experience other things, then they come back. They gain kind of like, yeah, I like it here, or yeah, I really liked how they did this. I'm gonna adopt that practice and do that here, or I'm gonna, I've got a little bit more experience. I can be a bit more of a leader. I can uphold the standards of care in the emerge or whatever it may be. I just feel like experience is just so important in nursing,
Well, it's totally, what
in
in
healthcare.
effect you brought to the table, right? Yeah.
Yeah, in healthcare,
Yeah.
residents, physicians, nurses, anybody. It's just experience is so valuable.
I totally hear you on that. So, open-ended opportunity, like if you had immense and unconstrained kind of opportunities to make changes or upgrades, or if you could fulfill your dreams of how we should be doing things different, what would be something that you could see would be a way to make healthcare in our neighborhood better?
I think if I had all of that, sounds great. I would open up a couple walk-in clinics and
Yes.
have them staffed and have them running, essentially not like Castlegar Urgent Care, but something similar to that where people can literally walk in and get seen. I think that would be helpful with the like lower triage level people in Nelson, at the KLH. And then um, I think I would just focus on improving flow in the emergency department um, and in Kootenay Boundary Regional Hospital, like the whole region. I think that the flow is good right now, but we're always so full. It feels like that I think I would try to see about improving the flow. I don't know how I would do that. That's the question. But I think the flow of patients in and out of the hospital, specifically out, we get people in just fine. It's getting them out. That I find to be the challenging part. Getting them to where they need to go is easy. It's getting them to a place of discharge that I feel like is the hardest piece. So I would try to improve that. Maybe more centers, or maybe the hospital at home, or maybe more like you can come in and get whatever you need and then go back home. Improve physio. I think we have a really good physio at Kootenay Lake Hospital, one of the best, I would say. And I think that if we could beef up physio, because another reason that people can't go home is because they can't ambulate.
Right.
They literally can't walk. And so it's like, if we could do 7 day a week physio, we're getting them up all the time. Where more care aides are on the medical floor. They're getting up for lunch. They're getting up for dinner. They're getting up, they're walking with the physio people. We just beef up their mobility because moving your body is so important. And when you're sitting in bed because you're so weak and sick and you're not getting up at all, it takes so much longer to get moving again. But they do it. It just takes so much longer.
Yeah, there's a real long-term rehab. I think on some level, like we have to involve everyone from the community in thinking about helping those who are the more frail or the folks who just have some physical disadvantages. That it might take a broader commitment on all our parts, neighbors and the like, to really like
Yeah.
come around and help those people. Sometimes I wonder if people just assume that the hospital has to do it, and we may not be the best place for every day of that strengthening journey.
Yeah, I would agree. Yeah, I mean, the Kootenay Lake Hospital, it runs really well. It's just we just don't have a lot of the resources that eh, there. And I get it. We're a rural site. We don't have. We're kind of the lowest level of care. Like it makes sense why we don't have it, but if we did have it, I think that would improve the outflow of patients.
Well, thanks for naming it. That's great. So, what else do you see in the near to medium future when you look out at 2025, as we just are here in the first month of the year? Do you see big things on the horizon, or stuff that's immediately coming up and is on your consciousness for how we're delivering healthcare?
I think just like continue to like raise the standard of nursing care and have like strong leaders in the hospital who like hold everybody accountable to being a professional. I think that's a huge piece. Um, right now is that we're all professionals working at that hospital, and there are certain standards that we should uphold. And to do that, we need to be accountable. And to be accountable is to learn from our mistakes. And someone needs to say, hey, you know, this wasn't done to standard. And, next time, we need to do vitals every 2 hours, or we need to make sure that we're documenting this and that and the other thing. And then that person could say, oh, yeah, you're right. Like, I don't know why I didn't do that. And I'm going to try to be better every day. And anytime someone brings it up to me, I'm not going to take it as a personal offense. I'm going to say, oh, yeah, you're right. I want to provide the best care that I could possibly provide. It's hard though when you're not supported. And so I think supporting people to look at it as like an improvement in yourself, essentially, to do your best.
You know
I
what?
think that's what I'm trying to do this year.
Excellent, and I'm grateful that you're on that job, and thank you for your role and how you um, contribute to Kootenay Lake and then Nelson and the greater community at large. Thank you very much for joining me today, Britt. I appreciate this conversation, and I have absolutely written down a couple of thoughts. I'll put notes to the issues that we raised in the show notes below, and I look forward to the next time we cross paths at the hospital. Thanks.
Yeah, definitely. Thanks, Jim.